Hello, everyone, and welcome to another deep dive session with Pekga, Practical EKG Academy. Today, we're going to be taking a look at this 12 lead ECG of this apparently very fast rhythm. We are going to be breaking it down starting with a single channel. We're not going to be going into 3 channels today. That simply was not available, was not presented on this ECG. So let's get into it. Of course, with any single channel ECG strip that you're handed, the only thing you can reliably pull off of this is rate and rhythm, right? And as always, anytime somebody mentions the word rate to you, your immediate response should be the rate of what? Rhythm, as you've seen more of these videos, I'm always skeptical when it comes to rhythm on a single channel, and hopefully you guys are catching on to the pattern here of why rhythm is kind of difficult to deduce. So let's get into it. As far as the rate goes, I'm going to be looking for a QRS that lands on one of these major lines here, so I can kind of pull the rate off. And here's a good one. So right here, starting right here, this is my 300 mark, 150. This rate is pretty fast. It's like 200 beats per minute. Now the 300 rule is not good enough. It's not accurate enough. I want to narrow this down a little bit further. So I'm going to be using the 1500 rule. So there's 5 small boxes in this big box, and then we have 6, 7, 8. This is roughly 8. It could be a little bit faster, but 1500 divided by 8 small boxes, we get a rate of 187 and a half. Not that that half matters. If you were to write 190 here, I don't think anybody would really care. The rate is so fast. So our rate is 187. When we take a look at the QRS is appears to be narrow, right? So it's running from roughly, and by the way, look at this, just to take a moment, and the quality of this ECG is not the greatest, at least the format we received it in is not the greatest. So I'm kind of guesstimating here that the QRS is roughly 2, maybe 2.5 small boxes wide. It's still narrow, right? It's still less than 120, and in this case, I think it's less than 110 milliseconds long. So this is a narrow QRS. The T waves are present, so the T waves are present. The QRS is narrow. The P waves, we can't make out the P waves. The P waves are somewhere in here, you would think, right? When we take a look at the 12 lead, we'll try to look for that. So the only thing you can reliably say here is you have a narrow complex tachycardia, right? Tachy meaning fast, and that implies that the rate is over 100. Here the rate is closer to 200. Now this most likely, since the QRS is narrow, is SVT, supraventricular tachycardia. Now that's an umbrella term, right? And it covers many phenomena. But here we appear to have SVT at roughly 190 beats per minute. So let's take a look at the 12 lead and let's see what we can, what other information we can pull off of this. When we get to the 12 lead, as always, right, you want to look at what stands out and then go into measurements, and finally, correlate this to any symptoms, which will allow you to maybe at least do a full ECG analysis, maybe even do a diagnosis of what's going on. So going back to the 12 lead, the first thing that stands out, the aspect of this characteristic of this ECG that's really up in my face is the rate. The rate is so fast. Now this particular ECG, we don't have a lot of demographic information on here. Not that it would help in this case, but this was this was a lady, a female patient, that was seen in the ER. When they took a look at the ECG, the first ECG yielded exactly what you're looking at here. So the rate is really overshadowing everything else. However, you go back to your basics and you start you start doing your analytics, right? So rate is at 190. The P waves are not visible. The T waves are there, the QRS is there. Now I'm going to take a look at the axis. The axis here, it's upright in lead V1. It's mainly upright. I would say that it's more positive than negative in lead 2, so it's upright in lead 2, it's negative in lead 3, it's isoelectric or equiphasic in lead AVF. So going to my axis finder, right, I'm going to be focusing on the AVF lead, which is right here, right? This is your AVF. Now, if the electricity here, or the potential is isoelectric, it tells me I should be taking a look at the perpendicular line of depolarization, which in this case would be lead 1. So going back to the ECG, if I take a look at lead 1, it is 100% positive. When we go back here and we take a look at this and we see that it's 100% positive, it tells me that the axis of depolarization, major axis of depolarization, is riding right around 0 degrees. So that's still normal. I do want to take a second just to mention that we do have left axis deviation is really divided into two segments. This is non-pathological from 0 to -30. Essentially, it is labeled as normal. And then we have pathological from -30 to -90. So this is an issue, right? So this would be an issue. Here, you're still okay. So this axis of depolarization is okay, quote unquote. Okay, going further. So axis of deviation is normal. AVR is inverted. I always like to look at AVR. That's a personal pet peeve of mine. I really like the lead AVR. It is inverted. Everything is inverted, so that's good. Lead AVL appears to be relatively normal. That's good. I'm going to transition over to the transverse plane of view. So we're shifting from our frontal plane, your Einthoven's triangle, your limb leads and your augmented leads. We're shifting over to the precordial leads. I'm going to be taking a look at the R wave progression. And where is my ECG? There it is. So here, if we take a look at this, we can kind of see that we have a little bit of an R wave before we dip into the major S wave, right? So the QRS complex is predominantly negative in lead V1, and then boom, it goes into a predominantly positive QRS complex in lead 2, V2. So our R wave progression or R wave transition is happening early. Okay, so that's that's a yellow flag. R wave progression, not a specific indicator of something, but it is an excellent non-specific indicator that something is going on in the heart. Okie dokie. So let's keep going. We have our rate. We concluded that this is narrow complex tachycardia, most likely SVT. Now, when it comes to SVT, there's SVT is an umbrella term, right? So SVT is an umbrella term, and let's see here. SVT can happen, covers a variety of phenomena. So this could be, for example, atrial fibrillation. What makes this very unlikely is the rate, the ventricular rate is so regular. Could this be atrial fibrillation with RVR, rapid ventricular response? Yes, theoretically, yes. You could have 10 seconds here where the RVR is incredibly regular. Is it likely? No. It is highly, highly unlikely that this is atrial fibrillation with RVR. Could this be, atrial flutter? I was looking for that, particularly in lead 2, and what I was looking for is this kind of sawtooth pattern that would be, kind of present here. And it really offsets the wave, so everything looks kind of skewed. I didn't really see that. So I'm not inclined to call this atrial flutter. There's two reasons for that. First of all, there's no squiggly line there, and typically, atrial flutter, if it was, this would be a one-to-one conduction, which would I would expect the rate to be greater than 200 beats per minute. If it was 2-to-1 conduction, I would expect the rate to be closer to 150. It just wasn't really settling down with me nicely. Another reason for that, in atrial flutter, it is possible, but you rarely ever see this TP segment that is flat. That's just very, very difficult to see with atrial flutter, or very rare, I should say. So I'm kind of going down the list of possible suspects, and you do have to, or I would recommend going to lead V1. Now the quality of these graphics is really difficult, and you will be in this situation. The worst thing you can do is learn from really great examples, and then you get out in the field and you're dealing with artifact nonstop, and you have no idea how to deal with any of this. So I'm looking at lead V1, and what I'm looking for here is R prime, right? R prime. So here, if I zoom in here as much as I can, you can kind of see this is your baseline, right? And you can see a deviation here, which I would call R. And then it goes down into this S wave. And there is a little bit of a deflection or a depolarization above the baseline. So yes, indeed, I would say that we are looking at R prime. Now, that is a telltale sign of atrial activity. So this would be latent atrial depolarization, which immediately would allow us to label this as AVNRT. Okay. AV, nodal reentry tachycardia. So AV, it pertains to the segments of the heart, the chambers of the heart that it involves. It involves the atria and the ventricles. Nodal pertains to the AV node. And reentry means it's forming a reentry loop. So you're going to have something like that, some sort of a circuit that keeps feeding back on itself. And tachycardia just means it's above 100 beats per minute. Right now, let me zoom out here. And when we're talking about AVNRT or AVRT, another suspect that entered my mind was AVRT. Now, typically, when it comes to distinguishing between AVNRT and AVRT, what you're looking for is the P wave. Is the P wave being hidden somewhere here, right? However, I'm not seeing anything consistent. This could be something. This could be something. Maybe this is something. It's so difficult to tell, especially with the quality of the strip that we have in our hands here. However, this R prime here is often present, and so in lead 2 you will have this it's called a pseudo S wave or a false S wave. Here I'm not so certain that this is simply pseudo S waves are typically smaller, right? So they would be just a little blimp. However, this is very sharp, very pronounced S wave. So I'm not so inclined to call this, it could be a combination of the pseudo S wave or atrial depolarization and a real S wave. Yeah, that it could be. However, this V1 is really telling me a whole lot more. And I am more inclined to call this AVNRT. Now, I did mention AVRT, or at least I think I did in my mind. The reason I say that is with AVRT, so let me go over here. AVNRT, you will have a narrow complex, you will have this pseudo S wave or pseudo R wave, depending on which lead you're looking at, right? So see that little blimp right here? See how it's different from here? Of course, this is a computer generated image. It's not a realistic one, but it is pretty close to what you would see with these types of tachycardias. And this is something that's happening in the AV node, or maybe slightly a little bit beyond it, depending on how the circuitry has been wired. Now, this is an extremely complicated topic, and we could spend a few hours just talking about AV NRT and how it's conducted, what's happening. That's a very, very heavy lesson. The other possibilities is AVRT. So there's no node being involved here. We're bypassing this node and we're going into atrioventricular reentry tachycardia, which can happen in two directions. It can happen anterograde, meaning it's following the typical path of conduction, AV node, His bundle branches. And or it can happen in a retrograde fashion. It can happen in a retrograde fashion where the tachycardia itself is going back up. So it's climbing back up the bundle branches into the His bundle, into the AV node, or perhaps an accessory pathway. So with AVRT, you need an accessory pathway. It's either going to be a Kent bundle or a James fiber or a Maheim fiber. It's one of these fibers is going to be involved where it's going to be bypassing the AV node. So you're gonna take the AV node out of the equation. And the reason why I'm mentioning AVRT is because if you have anterograde it's right in front of me, orthodromic AVRT, you're going to have a narrow QRS complex. However, typically the P wave is going to be present sometime late after your QRS. So it's not going to be buried in the S wave. It's not going to be buried in here somewhere. Well, it could be buried in the T wave, but it's going to be greater than 70 milliseconds from the onset of your QRS. And typically more than that. Typically it's going to be greater than 100 milliseconds latency after the first QRS depolarization. When it comes to the retrograde fashion, so here we're talking about a signal that's using accessory pathways, right? It's depolarizing the ventricles and it's climbing back up the bundle branches through the bundle of His and entering the atrium that way. You're going to have a wide complex tachycardia. And antidromic AVRT can be difficult to distinguish from wide complex tachycardias or ventricular tachycardias. And the telltale sign that you do have AVRT is a delta wave. So delta wave typically is going to be present when the person converts back to normal sinus rhythm. However, even that gets tricky because WPW syndrome comes in several different forms, and you will not always have an easily recognizable delta wave. Sometimes the delta wave will be buried within the QRS. So, a little bit of a discussion on the AVRT. Now, when it comes to AV NRT, there's two different kinds, right? There's the fast, slow, and slow, fast. And each one has a different telltale sign. Again, SVT, a very broad term. And this is something that hopefully we'll be going into a lesson where we're going to be talking about SVT, just about SVT. This is a little bit complex to understand what's going on here. I'd love to show you a couple of real-life examples, but essentially what this boils down to is where you are going to be finding your P wave after the QRS. So in this case, it's coming immediately after the QRS. So it's telling me that whatever's going on here, it's happening almost instantaneously, right? So as the ventricular depolarization happening, so is the atrial depolarization. Essentially, what that means is when you have this nodal reentry tachycardia, the ventricle gets depolarized. The ventricle gets depolarized, but also the atrium is getting depolarized. So what happens is you have a very large QRS, or your typical QRS, but then you're also going to have some sort of an atrial signature, and that comes in the form of that R prime or the pseudo S wave in lead 2. So R prime, you're looking for that in lead V1. Pseudo S wave, you're looking for that in lead 2. And that's what I was doing over here. So my main suspect, my main culprit here is AV-NRT. So I'm assuming this is a nodal reentry tachycardia. Now, going further, this patient, typically what happens when you get somebody with a fast heart rate, you kind of evaluate what are the possibilities, but the first treatment of choice in a clinical setting is a vagal maneuver, right? So here they're trying to stimulate the vagus nerve, the cranial nerve number 10, which slows down the heart rate through several different means. You can apply cold water to a person's face. You can have them bear down, like they were trying to do a bowel movement. In this case, they had this lady blow on a syringe, right? So, no needle on the syringe, but you just take an empty syringe, you have a person blow on it, and that really forces the vagal nerve to respond, to go into hyperdrive. And this is what happened. So this is what happened when they performed a vagal maneuver. The heart rate dropped down. Now, you could take a look at this and be relieved. Okay, great. The patient's heart rate has dropped. The EKG is looking normal. But again, go back to basics. So no matter what you're looking at, what stands out, and then always, always, always go to your analysis. Always go to your analysis. So going to our analysis here, if we're looking at this, the first thing I want to do is we'll pull the rate off of this. And again, I'm going to go back and find one of these QRSs that are on the line. I'm going to take a look at this one here. Here I can use the 300 method. So 300, 150, 100, 75. This is roughly halfway, maybe 2/3 of the way between 75 and 100. So I would say that this is roughly 90 beats per minute. As far as the ventricular rate, the P waves are present, right? So the P waves are present. Are they coming from the sinoatrial node? Let's take a look. P waves in lead 1, upright. P waves in lead 2, upright, right? See that? It's upright. P waves in AVR, inverted. P waves, I do want to take a look at lead 3 and AVF. It seems to be kind of a little blip up. So yes, for me, this is a sinoatrial node that is governing this rhythm. The next thing I want to take a look at is the PR interval. So PR interval seems to be normal, right? If it was not normal, you would expect it to be larger than this box. The PR interval is normal. The QRS itself has not really changed. It's still, well, here, this is probably a good place to measure it. We have our J point nicely labeled. So this is roughly 2.5 boxes wide. So the QRS is fine. The QRS is fine. Our basic measurements, the T wave is present, and here we can kind of take a look at the QT segment. So I'm just doing an R to R with a halfway point. The T wave is not crossing that at the baseline, so we're not seeing any QT issues. I do want to show you this. If you were to do the same thing as when it comes to the QT waves at this fast heart rate, you would have a problem, right? And that's why we have formulas which account for heart rate. But if you were to cut this in half, you would say, oh, this person has a prolonged QT. That's not the case. So when it comes to QT, you want to try and find a relatively normal rhythm or a normal rate to do this at. It will tell you a lot more. It's going to be a lot more precise of an analysis, if you will. Now, to keep going, let's take a look at the axis. So the axis here, it's upright in lead 1, it's down in lead 2, it's down in lead 3, it's down in AVF. When we take a look at the axis here, we take a look at the axis. So it's, what was it? It's upright in lead 1, it's down in lead 2, it's down in lead 3. We have left axis deviation. So something has shifted here, and this particular signature here, where you have an upright depolarization in lead 1 and negative deflection in leads 2 and 3, this is a telltale sign of left anterior fascicular block. These are also known as hemiblocks. So left anterior fascicular block. And what does that mean? Oops, where is it? So your left bundle over here, it bifurcates into the left anterior and left posterior fascicle. The ECG, when the heart rate slows down, tells us that there's a block, at least a partial one, happening in this anterior fascicle. And therefore, the conduction happens, right? It goes to the right bundle, and the conduction goes to the left bundle, but it only happens via the left posterior fascicle, which offsets the major axis of depolarization. It puts it, it pushes it, so we see it as left axis deviation here. So again, going back to this, right? Left anterior fascicular block. Looking at the fast heart rate here while this patient was in SVT, that is not present. So the left anterior fascicular block is not present. So what's going on here? Is this the same patient? Yes, it is. Yes, it is. These fascicular blocks are, bundle branch blocks, really any block could be transient, so they could be happening for just a brief moment in time, and that could be happening for several different reasons. It could be that the anterior fascicle is only partially degraded. It could be that the refractory rate, which is, I'm assuming that that's what's going on here, the refractoriness at higher rates, it's acting more normally, if you will. Now, again, that is complicated. We have to get into cell structure and what's going on with action potential, with action potentials, but the refractoriness at a higher rate is able to respond more adequately to the signal that's coming from above above the bundles in question. So here at a higher rate, this anterior fascicle is able to conduct properly. And so what we have here is a rate-dependent or functional fascicular block, which is unmasked during slower or more normal rates. And that is possible, and oftentimes you will see that with both AV-NRT and with both orthodromic AV-RT. Okay, now let's keep going. I'm going to switch over to the transverse plane. I want to take a look at the R-wave progression in the precordial leads, and again, V1 appears to be unchanged from what we were looking at over here. and immediately it gets really positive, right? The QRS overall gets positive, so the transition, the R wave progression transition happens very early. Okay, so we have early R wave progression. And what else can we see on here? Not much. The only other thing that kind of stood out to me when I was looking at this, when I was looking at the PR interval, right, I forget where we measured it, but it seemed fine. But here, and again, the quality here is not great. But to me, it looked like there could be a small deflection happening a little bit early here. Same thing in lead V2. The PR interval is still fine, but it just kind of seemed. Now, when you take a look at ECGs for a while, right, if you're looking at this all day, you're going to see all sorts of stuff that's not really there, it's just kind of in your mind. But we could be having a slight delta wave, maybe. Maybe. This is a maybe. The reason I mention this is because we're doing a deep dive, so we're exploring all of the options. Now, if you did have a delta wave in leads V2 through V6, you could potentially be looking at some sort of septal accessory pathway. So there could be potentially an accessory pathway that's located, in the septum of the heart, and it's allowing for this fast heart rate to happen with a narrow QRS complex. That is possible, in which case, this would be AVRT, orthodromic AVRT, and it would not be AVNRT. Does that matter in this case? No. Would this matter in long-term treatment? If this person wanted to get rid of this? Absolutely. Absolutely. And this is exactly what perhaps an electrophysiology study might reveal, or maybe an ECG caught at a proper time, where you could deduce, just based on the ECG, where the accessory pathway is located. Okay. So let's see if I'm forgetting anything on here. I think not. So let's recap here. You're handed an ECG that is fast. It has a narrow QRS complex. Axis of deviation is normal. We are showing a little R prime up here, so this would indicate that this is AVNRT. And the difference between AVNRT and AVRT is complex. There's a shorthand rule, and that is if your P wave is showing up, and let me zoom in here. So I'm measuring here from the onset of the R wave to wherever my P wave would be showing up, or your R prime as it was in V1. But let's say I'm looking for a P wave. So what I'm measuring from is the onset of the QRS. So the onset of the QRS to wherever, let's say the P wave was right here. This would be 80 milliseconds. So if your onset of the R wave, right? So onset of your R wave to the onset of your supposed P wave is less than 70 milliseconds. Now again, I'm not really measuring out something that's going on here. I'm just talking about the difference between AVNRT and AVRT, or long RP and short RP SVT, or narrow complex tachycardias. So if from the onset of the R wave to the onset of your P wave is less than 70 milliseconds, there is a really high chance you're looking at AVNRT. If it's greater than 70 milliseconds, there's a really high chance you're looking at AVRT, orthodromic AVRT. However, this is not a number set in stone. Okay, there's flexibility here, and there's actually quite a bit of flexibility. So when you go out into literature, these numbers can easily go up to 90 milliseconds. And even there's room for movement. So this is just one of the tools that we use when it comes to trying to differentiate, just using the ECG, right? So here we're not talking about invasive methods. Here we're just talking about ECG. What can you use to kind of quickly deduce or help you out? This is something that's very useful to physicians in a clinical setting, quick tips and tricks to help them pick which method of treatment they are going to be applying to this particular scenario. Okie dokie, so what do we have here? We have narrow complex tachycardia, right? We have SVT. We have SVT at 187 beats per minute. Call it 190, doesn't matter, which was converted using a vagal maneuver into normal sinus rhythm. So this is normal sinus rhythm. Normal meaning it's the rate is between 60 and 99 beats per minute, right? Sinus rhythm is coming from the sinus node, and with left anterior fascicular block. What else am I forgetting here? So this is normal sinus rhythm, left anterior fascicular block due to the axis deviation. And this is what would go into your report, right? We had SVT upon arrival, upon admission, of 187 beats per minute. It was most likely AVNRT. You want to put that in your report or not, it doesn't matter. It was successfully converted using a vagal maneuver into normal sinus rhythm. Heart rate was at 90 beats per minute, and we do have a presence of left anterior fascicular block. All right, and thank you for joining us on this deep dive. There will be a link in the description below for the shorthand or rapid ECG interpretation of this exact same ECG down in the description below. Feel free to check that out. Thanks again, and we will see you in the next one.